The subject is general surgery, colorectal surgery. There are two very distinctive speakers will be on the stage. The first speaker is Professor Dr. Sherief Shawki from United States. He's gonna tell us the technical tips in the single port surgery. Yes, the podium is yours.
Thank you. Assalamu alaikum, good afternoon everyone. I hope this is the last session, so thank you for staying. I hope we're still awake. And I also wish I can provoke some questions for discussion after the session. I would like to thank Professor Idis and my friend Professor Erman Aytaç for the pleasure of the invitation and Memorial in general for conducting that amazing program. So speaking of Memorial, I have to say I've enjoyed the day so far. They arranged and organized such an amazing robotic day. The scientific content, the discussants, and the organization was superb. So I would like to thank Memorial for such a great day. Thank you very much for having this. And I hope this is going to be a start for next collaborations. Today you have learned and you have heard from many experts about the usage of single port in surgery in general. You have heard about the chest cavity, and you have heard about the abdominal cavity, and you have also witnessed atmospheric docking for ENT and breast usages, as well as transinner and transvaginal. I'm going to be focusing about the colorectal. The laser is not working. So what's different in platform in all these specialties as opposed to colorectal? It is perfect for uniquadrant surgery. It is a very focused surgical field. Therefore, you have to understand the ergonomics and the dynamics, how to use it to go into different places. And the technology is excellent once you know how to use it and how to implement it and how to drive it. However, in colon and rectal surgery, we are not single quadrant. We are not a small organ. Any case, ileocystectomy, the smallest segmental resection, to subtotal colectomy, you are talking about at least 2 quadrants. It's not only that, it's not only the multi-quadrant surgery, but actually our organ, unlike any other organ in the abdomen and the chest, the more you dissect, the larger it becomes and the heavier it gets. Therefore, the instruments that are 8 millimeter for the XI become 5 millimeter and even smaller tips for the SP. Therefore, if there is one specialty that's going to have challenge in adopting the SP, in my mind, is going to be the colorectal subspecialty, not anything else. And it's like this. You are driving a perfect big truck on the left with anything you have, but now you have to drive the same pathway, the same street, and you have to do the same tasks with a smaller truck. So it may use more energy, it may use more time, but the destination should be the same, and the quality of driving should be the same, meaning don't use it. You have to be honest to yourself if you cannot achieve the same oncologic outcomes and the same safety outcomes for the patients. The good thing about the SP that you can put it anywhere you want, as long as you understand that you have 10 to 25 centimeter extension and retraction. You can put it above the surgical field, you can put it opposite the surgical field, you can put it in the middle, which is a good characteristic for the SP, but you need to know how to operate the SP in order to be able to do it from anywhere. So uses in colorectal surgery includes whatever from this list, but when you start implementing it, you need to implement it in a procedure that you are very, very comfortable with. In my mind, trying sigmoid colon first, better than right colon. Trying appendectomy even to just get used to the ergonomics and how to move, and trust me, you will struggle in the beginning. It's okay. Don't give up hope. You just keep, the idea is not to do the appendectomy. The idea is a small procedure that you can do it safely to get used to the new vehicle so you know how to drive it. I used the SP in different types of segments, and the first case I'm going to show you I'm a big proponent of transanal total mesorectal excision, the TATME. I know not everybody believes in it. I know people have concerns about it, and I respect and I agree on all of these concerns. But I've been one of the people who have used it and took it to the next level in USA. So I combined the TATME approach with the SP for low anterior section. So here, as you can see, the proctotomy, I already took the occlusive rectal suture, and I'm doing the proctotomy, and I do it in layers: mucosa, submucosa, musculosa, and then I enter the plane. This is posterior, and I am getting into the TME plane. No laser? It's okay. So when you do TATME, you dissect actually immediately in the levator hiatus, which is basically where all the levator muscle comes together in preparation to become the anal canal, and you only see the levator muscles there. And then you enter the true pelvis after that. And this is what I am doing here. You identify anteriorly, which is the prostate in this male patient, and then there was some bleeding from radiation. And I don't have control to go forward, so I apologize. It's going to take a minute, and then you're going to see good stuff, or better stuff. And now I'm taking something called the anococcygeal ligament, which actually starts in the pelvis with the confluence of the pelvic floor, like the rectus abdominis and the linea alba. This is something equivalent to it. And here I'm entering the real pelvis, and there I'm entering fascia of Valdyers in reverse, okay? And the same thing I tell my fellows from the abdomen: you stay between the fascia of Valdyr and the mesorectum, you stay also here. And my point of this is I'm gonna do complete rectal dissection from the pelvis to save it, to save my energy to do only the colon and IMA from the abdomen. Here I am taking the lateral stalks. This is the right patient side lateral stalk. And you can see these are all neurovascular bundles and nerves. And now you can see I'm curving medially. And you can see the seminal vesicles and the vas is there. And then I already cut the peritoneal reflection anteriorly. This is not SP, but for me, this is my next journey. I would love to do SP transanal total mesorectal excision using the anus as a natural orifice. So this is my next task. A couple of my friends in the US, they are actually trying to do this as well, and they have succeeded. So it's doable. I just need to see how it is doable and feasible and safe in my hands. Now you can see I'm going to push. I'm finishing the right side of the peritoneal reflection, and the whole rectum now is going to be pushed in the abdomen. So it is doable. It is and it saves a lot. And then here you go. You can see I'm at the sacral promontory there. So I'm going to go to the next one. This is the stoma site. I already put the bubble in. I used to use the port, the 2.5 centimeter wide and 9 centimeter long. Now they have the bubble, which saves you a ton, which is very good. It takes a while to get used to how to assemble it, though. And then you're going to go in. Again, it moves in unity. You have to retract your arm in, and then you have to move like the right side or left side. I'm going to show you everything how it happens with the SP. I'm doing here sub-IMV dissection to mobilize the splenic flexure because I extract transanally. So I need the splenic flexure to be fully mobilized. The IMV is up. This is the duodenum here, ligament of Treitz. The pancreas is here. And now I go lateral to medial. I did not try to do medial to lateral with the SP yet, but I can do it laparoscopic or multi-port robotic. But I see benefits in doing lateral to medial for easy of mobilization and easy of using the small arms with the small spans. Another thing I found that when I am in the right plane in the transanal approach, the air dissects the colon and make it easier for me in the transabdominal approach. And you will see how good it is, because I'm going to medialize the colon completely. I'm going to even identify the IMA from the lateral side. As we are talking about colorectal surgery specifically in relation to SP and in comparison to other specialties, the colon is the only organ that you have to put it back to its embryological position when you are resecting it. Embryologically, the colon is a midline structure. It's the rotation that results into having the right transverse left colon. In order to do oncologic resection, you have to put the colon back to its embryology. You have to put it back into midline. That's why it gets longer, it gets floppier, and it gets heavier. You can see now I'm recording myself from the bottom there to kind of see what mistakes I'm doing and how I'm moving my arms. I'm learning from my own mistakes, and I'm going to show you that part. And then I'm finishing completely dissection here. And the rest of this, so I don't waste time, and the rest of this is, as you know, complete medialization, go medial to lateral, follow the superior hemorrhoidal, get the IMA high. Now I'm recording myself. One of the things that I had to learn with my team is how to go in. We are a little bit going, and one arm will catch the abdominal wall. Number two, which I'm going to show you in another video, is it has to be in line with your quadrant. Otherwise, the camera and the arms are going to start lifting on the abdominal wall, and that will cause trauma. The patient will wake up and will tell you, I'm fine, but I have pain here, nagging pain here, which is muscular trauma. And now you can see how you are doing this and how you are working. And I'm going to have another video that shows this in a better way. Okay. I'll follow. Now, this I always do. I have the luxury to do cadaveric lab for myself, where I try and do things outside of a live human being, so I can try new things without causing harm. So this actually was one of my cadaveric labs. And I recorded myself using the SP to do right hemicolectomy. So I can understand what are the ergonomics, how it works, and what I can do it right and what I can do it wrong. For those people here who are doing robotic surgery, you know you are sitting on the console and your head is envisioning what's happening on the table. External collision, internal collision. You do it a lot that you actually adapted that memory of vision. We don't have this here. So I needed to know what happened when I move my arms. This is how it works. So it goes in, and it works, as I said, it moves in groups. Now, you see only what's in front of the camera, so you can cause harm by this. So you need to be aware that something like this you may injure, most likely not. But if you don't see the tips, and the tips pull a mesentery, all what you're going to see 5 minutes later, pool of blood in your abdomen. So be careful, because it happened before. Now, I put this ruler there to show two things: the span of the arm movement, and each arm in relation to the neighbor, to the next arm, how you can move, okay? This is the middle arm, this is arm 3, and this is arm 1. And you can see, if you have an arm between 1 and 3, you can overlap. Two arms next to each other, 1 and 2, and 2 and 3 cannot overlap. However, going up and down, that should be okay with all the arms together. The span from the middle to lateral side, 7 to 8 centimeters. When you overlap 4 centimeters. So you are talking really about specific surgical field. And that's why, in order to fit into our colorectal practice, we have to find a way how to drive it, how to do it effectively. I think extra half an hour, 45 minutes, with similar outcomes, I'm happy with that. But extra 2 hours, that's too much for my patient. Now, could you please advance to minute 6? Good, thank you. So I did the ileocolic here. I lifted the ileocolic, and I'm making medial to lateral dissection. The camera now is in the cobra head, but I'm looking up at my ileocolic pedicle. And I don't take the vessel early. I like to create my tunnel underneath the right mesocolon. So right now, I don't have the visualization that I want to see specifically to get my tunnel established. The reason I don't take the ileocolic vessel early is if you take the ileocolic vessel here, that part of mesentery is so fragile that you're going to cut through the mesentery, and in my mind, you will have incomplete mesocolic resection. Therefore, I like to keep the vessel, and I like to drop down the D2, D3, and even separate the adjacent portion of the head of the pancreas. And now I know that I have a good mesocolon, that I can do a good oncologic resection. This is part of the docking, and this is the part that you and your team are going to get used to it the more you do it. When you struggle in the first 5 to 10 cases, it's okay. But it's as easy as this. Imagine that port side is a stick, one stick, that you have to make it a straight line from the boom to your target. So you can actually, more than you think, you're going to have to put the boom all the way down to get inside the abdomen and go to the quadrant as a colorectal surgery. And here is how it goes easy, and then you can expand. And there is one thing I want to show you. I'm just going to go do it myself. Can you go back a bit? Can I use this? So here when I'm having the vision from up, I cannot see below, and this is the 180 twist that I like a lot about the SP. That twist, put the camera down, therefore I can see everything underneath the mesocolon, and I can finish my dissection. Another thing I wasn't able to produce here, that the professor who spoke in the gynecology session, he's very good. When he said about you can do the horizon and you can switch the horizon, the more you do from those, you will learn that you can actually look on the side. But the view is going to be altered for you. So you don't do this in the beginning. In the beginning, stick with basics, stick with the fundamentals of anatomy, and then when you get more comfortable, you start doing the 45 degrees horizon shifts, okay? But as you can see here, I already entered my tunnel, and I'm dropped the duodenum down, and I'm doing the procedure the way I want it. I am happy to share any of my videos with anyone for educational purpose, okay? Now, this is my view when I was doing that cadaveric course. This is what I was seeing, and you can see what's the mistake here. I see only the tip of the scissors. I don't see the other tips. So now I'm demonstrating what can go wrong, because this is what we need to learn and teach each other. What you do wrong and what I can avoid in my next experience, and vice versa. So you need to see, and that avatar shows you what's going on. So one of the things that you need to train on in the simulator is to learn how to read the avatar. I had problem in the beginning until I learned how to read, and it made me understand what's going on with that triangulation inside the abdomen. This is another one when you're going and hitting, but this is from the robotic view. So your assistant, when you get the camera out, and you have been pulling on the abdominal wall, and the assistant get the camera out, they cannot put it back in. They have to shift the port to be one line through the hole. Otherwise, you will hit the side, the wall of the ileostomy. And this is showing you the distance that I was telling you about, and you can go up and down without a problem. Between two arms, you can go lateral, and you can cross 4 centimeters, lateral 7 to 8 centimeters. But two arms next to each other, you cannot cross. It's going to be difficult. So what does this mean? This means that when you are doing any surgery, you know that most likely you're going to retract, for example, with arm 3, which means your arm 2 can only work this way together. You cannot cross them. If you want to cross them, arm 2 push down, and arm 1 and 2 goes together. They can work together. This is the implication of what I'm telling you here. The last application that's going very well in colorectal surgery now is the transanal approach. The transanal approach, many of us who don't have robots, we do laparoscopic transanal. And we become good because we are forced to do it. We were forced to do it that we became very efficient and very effective in it. But we understand that closing the defect is a problem. So this video here, for honesty, this is not me. This is one of my prior partners at Mayo Clinic. He is using the XI as multi-port through the anus to take a polyp out. And you can see the movements are really, really, really smooth without a problem. The way you can hold the needle from any angle and you can sew, it's amazing. It's so helpful. You can push the camera up and you can see the proximal side, anatomical proximal, which is for you transanal distal, and you can get a good margin. From you, the surgeons from you who do this laparoscopic, you know this is not easy, especially when you have Professor Ataf was talking about it in the session, that when you're standing together and you are pushing here and there, but this happens. But with the robot, that's eliminated. Now the SP for transanal is such a great tool. And so far, if you tell me, what is the only implication that you can suggest or recommend, I will tell you definitely transanal. And we are still trying to find our sweet spot for segmental resection in the colon. This is rectosigmoid, guys. This is deep in the rectum. This is at the third valve, above the third valve. And you can go there and you can do whatever you want, which you cannot do laparoscopic, by the way. I would challenge you to do it laparoscopically. Am I good with time? Thank you. You can see the muscle layer. Those from you who's interested in the transanal, you know, sometimes we as a surgeon, we want to do submucosal dissection, and sometimes we want to do muscular dissection. We don't want to get into the mesentery in case that part is T3. But if you have T1 and you took this polyp out, right now, according to NCT guidelines, done. You just survey the patient. New data are coming for T2s with the prognosticating factors. For T2 rectal cancer, you may not need to do low anterior resection. So this is a big era now in colorectal surgery. So single port robotic platform in colorectal surgery definitely has potential from our perspective. And I shared with you why it has potential, because as organ, we are different than any other organ in the abdomen. We get longer when you dissect more. We get heavier when you dissect more. Therefore, we have to find how we can drive the small truck versus the big truck to get to do it better. Experience and high volume. I don't think I need to emphasize that. We already know that high centers, high volume surgeons have better outcomes. But not only that, you need high volume surgeons to teach the next generation, the next fellows, how you can teach them, how you can tell them, no, grab it this way, hold there, move to the right. The same way we are comfortable doing robotically, conventionally, you have to be comfortable doing it, reproducing with this way. And it's a stepwise approach. You cannot just run. You have to learn how to stand up first, independently, walk, and then you can run. Honesty and transparency. Whenever you're trying something new, I don't care about your leadership, but you have to be honest to yourself and honest to your patient. If you can't do it, it's okay to say I can't do it, and I will have my partner does it. Because this patient, if this patient, you imagine this patient is your family member, and you will think twice, then you should not apply it at all. And collaboration for such techniques is the best. When I do 5 cases, and you do 5 cases, and Erman does 5 cases, and we meet together in such meeting like this, and I enjoyed and learned a lot from the Gynonc team today, the Urology team today, and the Thoracic team today. I'm going home with good tips that they shared with us. And with that, I would like to thank you again for the pleasure of attendance today and the opportunity to share my experience with you. Thank you very much.
Thank you very much for your didactic presentation. So the second speaker is Professor Erman Aytaç. He's going to speak about single port surgery in colorectal and gastrointestinal oncology. Where are we today? Yes, the podium is yours, Professor Aytaç.
Thank you very much. Thank you very much for giving me the opportunity. It's a great honor to be part of this project. I would like to thank all the memorial management and organization team, especially to Professor Bimbay, who is leading the way for us and changing the practice and vision of our approach in the field of abdominal and thoracic surgery. So I'll be talking about the general tips and the status of the single port robotic surgery after my dear colleague and classmate, Dr. Shawki. So we'll be talking about why single port, why now, that's technically difference, where the evidence strongest and where are we now, and what are the oncologic metrics and who is the right patient to start in the practice, and can we build a program for single port surgery. So surgical techniques in a evolution period, since with the application of laparoscopic surgery, we started to struggle with the laparoscopic instrument, and robotic platforms are built to overcome these limitations. And then we noticed that we can do some of the operation with less port insertion, with smaller operations. But at the beginning, as Sherief pointed out very well, it's not only the incision, it's to catch up with the high quality, with the prevention of the patient safety. This is an image that we did 15 years ago with my mentors. We are the one who did the very first laparoscopic single port total mesorectal excision in 4 patients. And we didn't do it again because of the struggling with the instruments. And we waited until we have the proper time to start this program again because of the lack of the triangulation, vision, and other implication of the technology. We also showed the applicability of the single incision and reduced port techniques in the field of inflammatory bowel surgery with reduced port technique. Sherief remembers those days. We were together in the Cleveland Clinic with Dr. Costerio, and also showed that in tough patients, the single incision surgery can be done laparoscopically, but we couldn't proceed because of the limitations. This is the video that was published in the JAMA Surgery at that time. If you send this video any journal right now, you will be rejected in 10 seconds. But this was the very first and the most advanced visual technology that we have at the time of early 20s, and we are trying to create triangulation with different approaches by tacking the sigmoid colon to the abdominal wall, all for trying to create the proper traction and contraction to the operation. Now we have better instruments with the help of technology. The era is coming back again, and we are trying to move forward with less incisions. With the multiport technology, we try to do the transcendental operations from the single site, but this is very premature application of the instrument, but you can also do local excisions to TME operations with the multiport technology. I would like to mention also about how we approach to the patients. We are not only carpenters, we are doctors, and we are trying to evaluate those proper patients by evaluating all the aspects of the disease. In the colon and rectal cancer surgery, there is only not improvement in the field of surgical technology. There are also many improvements in the field of oncology, and we should be aware about the microsatellite instability, neoadjuvant treatment, ctDNA, and all the neoadjuvant applications. These are not only literature data. The field of our operative field is moving right now. We are getting advanced patients which are not operable at the time of diagnosis to the operable stage, and we are losing some early stage patients to the gastroenterologist or non-operative treatment alternatives. But why I'm telling this, we will apply all this advanced technology to those practices, because I will talk also about the learning curve with the easy applications. But those operations should be done in tertiary referral centers, not only for increasing the numbers. Cancer operations, organ preservation operations is not only one-man business. It requires a multidisciplinary team. So we should be aware about how to approach and prepare those patients with the proper staging strategies, and we should also know about the role of immunotherapy and chemotherapy, not only just for the literature mind, also prepare the patient to the operation. And in the field of colorectal surgery, at least 10% of the local disease which are not distant, it doesn't have distant metastasis, has T4B level. And as we all know, even for the advanced stage, when you do the operation, the long-term outcomes related with the success of R0 resection with positive, negative margin, and lymph node status, which is very important step to evaluate a proper operation, also to understand real stage of the patients. And with the time, even for those patients are being operated, not only removal of single organ, also removal of the other organs which are invited by the tumor. This is one of our multiport resection. Now we are not only removing single organs with multiport, we are doing pelvic exenterations with multiport. So the idea is always the same. Sherief talked about the technique of the operation very well. So what you do in open operation, you have to do with the similar applications in the minimal invasive operation. So if you do a rectal cancer operation, you have to take the inferior mesenteric artery from the top. You need to take the inferior mesenteric vein from the below the lower margin of the pancreas, not only for only oncological reason, also to move the left colon for a proper anastomosis. So those operations also require sometimes removal of the other organs, including the uterus and the ovaries, or if it's invited by the tumor, the urinary bladder have to be removed, as you see here. Now we are getting into the urinary bladder. This is totally robotic procedure. So of course you have to start with easy cases, but the idea behind doing these all MIS procedures to do all type of oncological procedures from the access site, which is multiport or single port, and then not to harm an organ which is not related with the disease itself, such as abdominal wall. So I would like to point out one surgeon who is our founder in Cleveland Clinic that we trained with Sherief. Rupert Turnbull pointed out the importance of the surgical treatment 60 years ago, and he reached out more than 80% 5-year survival for the operative colon cancer, which is very close to our levels right now, with just only surgery. So why I am talking from all these, we have to improve the quality of surgery, regardless of what type of neoadjuvant or adjuvant treatment that I mentioned before is important. It ends up with a good quality of surgical treatment, regardless of the neoadjuvant treatment application that we also defined our approach for rectal cancer. Even for the rectal cancer cases with the complete response, they will prone to develop regrowths. So these regrowth patients also prone to have poor surgical outcomes. So when you have a rectal cancer case operated, if you don't operate and go to the watch and wait period, it's nice. But if there is a regrowth that we don't know the denominators, what is associated with regrowths, the outcome get poorer. So you need to do a good TME. So it's a TME the king. Then I'm coming to single incision again. We are not taking this instrument to do appendicectomies, of course. We are taking these instruments to do advanced oncological resection. So it includes all the difference with access, articulation, alignment, and the application of the technique. And you need to apply different approaches compared to the multi-port strategy. This is one of our operation in the upper with the multi-port, and this is our single-port surgical approach. So all the information related with the multi-port technique is changing with single-port application because the traction areas are small. You can reach any part of in the abdominal cavity, but the approach that we used to do in the multi-port strategy, it changes. So you need to do proper dissections in the small triangulation area, and there are differences not only with the port number, the camera is different, as Sherief mentioned very well, and the instruments are not as large as as thick as the multi-port approach. And in the evolution of the single-port colorectal surgery, it started with the application of the platform in the United States and the Western area, and even with the complex intersphincteric resections can be done in our time with single-port robotic instruments. And when we criticize the early steps related with the single-port technique, why we are doing this, we are not achieving better oncological outcomes, we are not achieving short-term recoverability benefits compared to multi-port. It is the learning period for everyone. We are applying robotic surgery for the last 15 years. We just have a randomized level evidence clue for superiority of the robotic platform in the field of rectal cancer surgery. This paper is a turning point paper from China. They create a very advanced and very nice study for comparing the laparoscopic and robotic surgery in the field of rectal cancer surgery. So they proved when you operated by robotic surgeon, which is experienced in rectal cancer surgery, 3-year disease-free survival, local recurrences are higher compared to the standard laparoscopy. So it is coming. And right now, the number of lymph nodes, conversion rates, operative time is similar with the multi-port, but with the time of the evolution period, I believe with the long-term data, we will see more benefits of single-port surgery when we all get experience in this field. And the superiority of the instruments with the more delicate and definitive dissection area will be seen in narrow areas, including the pelvis and including also the esophagectomy procedures and gastrectomy procedures when you start to do hand-sewn anastomosis rather than stapling anastomosis, which may be very crucial if you're trying to achieve more than 2 millimeters safe margin area for such a tough patients. In rectal cancer surgery, there are still some case series showing with the similar outcomes compared to the multiport robotic approaches. There are some studies about learning curve. It really changed. The number doesn't matter. For a person who started oncological surgery, they need to know the principles at the first, then they need to engage the MIS and then robot. This will take maybe 100 cases to learn single port. But for an expert in the field of multiport robotic surgery, I think it will take like maybe 10 cases or lower to apply these procedures in their routine practices. In postoperative recovery periods, it's really related not only the technique, sorry, it's also related with how you apply enhanced recovery procedures. Are you applying the bowel preparations or how you started the diet and etc. There are some clinics still doesn't giving regular food to the patients maybe 1 week later after resection. It is not the way only related with applying the technology, it's also the way how you apply your stuff to the postoperative follow-up. So it's really variable, but the overall morbidity rates are very acceptable. And when you check the case series oncological outcomes, the lymph node numbers, the CRM positivity, TMA quality, and the distant radial margins status are comparable with the other larger series. And when you evaluate cancer surgery, you don't measure the incision length. When you have the patient report, you check the pathology report. And the pathology reports or any study evaluating the operative outcomes should include the resection margins, TME quality, nodal harvest, and conversion numbers. And to me, the conversion rate is not a parameter for the surgical quality. It can be related with the patient's condition. And conversion is not a mistake. Conversion is a self-evaluation decision should be taken very, very earlier to not to harm and not to create a drawback in the operation. So the conversion can be the last parameter to evaluate surgical quality, especially at the beginning phases. This is our oncological outcomes with the multiport technique, and we are very proud of it, and we are achieving almost more than 90% TME grade 3 resections in our routine practice. And our complete response rates are around 10% because most of the patients now are being followed up with the watch and wait strategy. These are the resection outcomes. So the resection outcomes, we are around 10 to 6% for the complete pathological response in rectal resection numbers. And we are not only applying the regular chemoradiotherapy operations, we are applying TNT procedures, which is also causing additional drawbacks during the operation because we are sometimes operating a patient after completion of 6 months after completion of radiochemotherapy, which is a major drawback by creating fibrosis and all the issues related with the adhesions with the organ and the tumor area. And we also have some of our colleagues which are also here to be trained in our centers. And the training is not a part of getting into the operating room. As Sherief pointed out, it should be started with the simulation and dry lab. You should be oriented about the technology. Then you can move with the cadavers or the animal laboratories, and you can start with the benign cases, then start with colon, which is sigmoid colon is the best choice to start, and then you can start with the right side or rectal cancer operations, and then you can evaluate your outcomes and improve your technique. But it's not only the marketing issue, it's a program totally. And for early adoption, we recommend with the benign right colectomies, sigmoid colectomies with early cases. I don't recommend sigmoid diverticulitis, which is also a complicated case. And then with your experience, you can move with the advanced cases with low anterior resections, TME. then you can move forward maybe for the multivisceral resections, but it requires a time and the structure. This is our approach in Memorial Group as a GI group. We are applying all these parameters to our steps, so we are not just jumping into the field, we are creating the people around, and then we are following up our outcomes. Then we are moving forward, and we are also creating education program for our residents and our other colleagues in national and international areas. So it requires time. This is our case with single port. This is a T4 case that we did a couple of days ago. So it's not a good selection maybe for participation, but the mentality is the same. So if you create proper traction and contraction area, you are just trying to find the planes, then you move forward with following up the planes. We are doing medial to lateral fashion. This is our tradition. We don't do lateral to medial, but this is a completely related with your experience. They are both acceptable. And in those cases, you realize the edema related with the obstruction, but doesn't matter. We are following up the God-given planes, and then we are doing the completely similar resection with how we do in open laparoscopy or multiport robotic surgery. What we notice in these patients, even for an obstruction tumor, you can access to the abdominal cavity with a proposed area that with the ileostomy site. And we didn't do ileostomy in this case. So the advantage of the single port arms are related with the dexterity. In addition to its maneuverability capability, their structure gives you a visual haptic sensation. We don't have this in multiport surgery. So with this, you can go more precisely for the delicate regions. I am trying to dissect the inferior mesenteric artery. We always use the clips. We don't like the vessel sealing devices because in my practice, it's losing my way to find proper dissection plan. You can go slowly to create an adequate place to apply clips. We use Hem-o-lok clips. So far, we haven't had any issues with Hem-o-loks. They are pretty safe. 5 millimeters Hem-o-loks are almost always enough to do proper application. 2 clips below for artery. 1 clip is enough for vein, because veins sometimes can be more delicate with clip application, so the safety, of course, always first. And then we are moving with the same principles how we do in multiport or open surgery. You see the left colic upper there. In male patients, we don't go that below to the apical to the aorta. We dissect the lymph nodes, but we are trying to prevent the hypogastric nerves. And you see the edema related with the obstruction. But when you use how to create the triangulation with your visual judgment, then you can do exactly the same operation. Unfortunately, in our country, we don't have the single port stapler yet. So it's a drawback. For stapling, you have to create an additional port. The single port entrance area is not appropriate for rectal transections, but the FDA approved this device. I think we will have it shortly. Then we will create maybe the more advanced applications when we have more experience with the single port. So the future is also going with different direction, inclusion of the image-guided surgery, artificial intelligence. We will have more tools to help our operations. This is a Japanese group. They create the Eureka system. Basically, in this system, they point out the planes. You can see the blue dye. This is the transection area. This is an easy case compared to my case, but in future I believe there will be more advanced instruments. Those instruments will also show us the neurovascular bundles, ureters that we will see here. So in future we will have more of these devices. And there are also some applications with the perioperative imaging guidance operations. So application of the simple CT scan, especially for the right colectomy, with all the variations, may help an application of these instruments to the robotic platforms with artificial intelligence. I believe the quality of the operations will increase. So it is a safe and feasible procedure. We have the short-term results, yes, in the field of general surgery. It's not oncologically superior yet to the existing multiport technology, but with adoption of the precision, with discipline and evaluating the outcomes regularly, we will, I think, reach in a certain degree. I would like to thank you for your attention and would like to thank my team for their support. Yes, sir. Thank you very much.
I would like to thank Professor Aytaç for his very instructive presentation. So let's have the two discussants, Dr. Sevinç and Dr. Tanal, to the podium for interactive panel. First of all, I would like to ask to the floor if there are any questions or contributions from you to the speakers. Yes.
Question for Professor Sherief. We enjoyed your excellent presentation. It was great. The question now, if you have a terrible bleeding from the plexus, veins, to the pelvis, and of course you convert to multi-port robotic or open surgery right away, and how you stop bleeding.
This is a very good question. So I'm going to step back a bit. If you are doing multi-port robotic, let's say XI or DV5 low anterior resection, and I do my own lateral pelvic lymphadenectomy for metastatic rectal cancer for extra mesorectal. And it's not uncommon to encounter this bleeding, and anyone you can work on except two areas. The two challenging areas are the left common iliac vein, because it's stuck to the sacrum on the left side, and when it happens after TNT, the fibrosis, and you know how the vein wall is very tenuous, and it's very hard to repair. The second spot that's very hard to control is distal in the pelvis, especially the inferior gluteal vessel, which is one of the distant branches of the internal iliac vessels. And the reason for that one, the difficulty in this one, in addition to fibrosis from the radiation, it is at the end of the cone, and you have to dissect while it is actively bleeding to go beyond it so you can control it, because it bleeds proximal and distal, because there is retrograde blood flow from the gluteal artery. With the XI multi-port, the good thing about it, and I have all my fellows learn that, which is a very good question. The XI has this characteristic. You can put your tip on the bleeder, stop the bleeding, leave the console, go scrub, open the abdomen, undock the other instruments, move arm 1, 2, and 4, leave arm 3 on the vessel, for example, open your abdomen, and arm 3 is grabbing it. And then there is something called the key. That key, when you undock the arm that has the tool that's grabbing the vessel, you have to go with that key. It's unsterile. You open the tip under control, you put your hand on it, and you take care of it in the open fashion. This if you cannot control it. With the SP, you can do the same because it's a single port and usually from the side. So you can control it, hold it, let it be, open, and then you have somebody sitting on the console, release, and you can put your finger on it if you have such a bleeding with the SP. Did I answer the question?
Thank you. Another comment or question from the floor? Let me ask Erman a question. Honestly, what do you prefer if you have a rectal cancer? Prefer a laparoscopic surgery, a single port, or a multi-port? And why you prefer? Would you mind explain us?
Of course. I would like definitely go with the robotic surgery for rectal cancer. For me, there is no question unless there is a other limitation, because robotic vision also created us an opportunity to understand lower rectal anatomy much better compared to laparoscopic surgery, because the visualization capacity is higher, and it gives us the opportunity to do many maneuvers for dissecting especially the lower tumors, which you just basically cannot do with laparoscopy, and I'm experienced laparoscopic surgeon also. So about single port and multi-port, I think single port platform is capable of doing all type of colorectal operations, but as I mentioned, we don't have the stapling device yet, and if I create like 1 or 2 additional ports in this stage, we can go with single port for more lower rectal patients, because I believe single port equipments are more superior for doing delicate dissection compared to multi-port. But if I have the 45 millimeters stapling device with the single port, maybe we just do the rectal dissection with just ileostomy site. An additional 5 millimeters area will be used for just the drain. And for colon resection, we don't use drain, and I think single port technology will give us the opportunity to understand anatomy better, and I'm expecting for the next generation robot, which are my wish is with the both single port and multi-port platform, then it will also increase, I think, our organ preserving strategies and also our approach to the lymphadenectomies. Now we are standardly do the TME and CME for every case. I mean, if it is a T2 tumor, we do CME. If it's T3 tumor, we do CME, which is our standard, because for sake of apical lymph node positivity and other tumor deposits, I think those argument will continue, and the single port platform is not the top. So it is just one step in the evolution process. So I can apply both of them, depending of the patient characteristics.
As an expert surgeon, a robotic surgeon, let me ask another question to you, and also Dr. Shawki. What do you tell about the young fellows who starts with robotic surgery? Will they start with the single port, or have some experience on the multi-port robotic surgery, then after maybe some cases? What do you offer? What do you recommend?
This is a very good question that I can take an hour to answer this question. So I try to focus and not drift away, because I'm like you, Professor Idris. I don't like a fellow who comes and say, I am seeking a colorectal fellowship for robotic surgery fellowship. That fellow, I cross the name. My partners like that, but I don't like that, because I don't want to create a robotic dependent surgeon. I want a surgeon who can do open, who can do laparoscopic, and who can do robotic. When the need arises, if this surgeon is operating on my mom or my wife or me, and he needed to convert, I want him to be comfortable to convert. So this is number one from the educational standpoint. Very soon, it's going to be the opposite. When I was a resident, there were cadaveric course to learn laparoscopy, and then cadaveric courses to learn robotic. And I'm telling you, very soon, we are going to do cadaveric courses to teach the fellows open surgery, how to do open surgery. Because when you are operating with a fellow or a PGY5 resident who's going to be general surgeon in a few months, and you do open with them, they are clueless. They don't know how to retract, they don't know what to do. So to answer your question, if I have a fellow, I will have them learn the anatomy, surgical anatomy and techniques, open, and then multi-port before single port.
I agree.
What about laparoscopic surgery? Does it have any role in this sequence? Can you put it anywhere?
Of course.
I also asked Dr. Tanal the same question.
Yeah, definitely. I mean, all the platform just enough to cover less than 10% in globe. So laparoscopic surgery stands there and definitely will be one of the main approaches for applying these operations. But at the time, I think there will be an algorithm to apply this, and we are going to in a way where more artificial intelligence with less incision. And I think 100 years later, they will maybe laugh at us because we are just cutting the skin because of removing the colon. Maybe there will be no surgery, we will see. But laparoscopy for now, gonna stay definitely. What do you think, Matt?
As the youngest surgeon in this session, first, I'm really honored because I was a third grade medical student and I just went to an observership in Cleveland Clinic, and Professor Aytaç was there as a fellow, as a surgeon, and I'm really honored to be with him today in the same session. I think a surgeon must do both open, laparoscopic and robotic surgery, definitely. And they have to learn both open and laparoscopic if they need to convert. So, but for example, inguinal hernias, during our residencies and in the first years of being a specialist, we've done a lot of laparoscopic inguinal hernias. After that, when I switched to single port, I've done just 3 or 4, but it was really lovely, and I've done it really good. But you have to be really good in especially TAP if you want to do single port inguinal hernia. But for colorectal cancer, for example, I think you have to finish your learning curve in multiport robotic before getting to SP.
I would like to have the opportunity right now because we have a hernia expert as Professor Altınlı here. What do you think about single port inguinal hernias?
First of all, it's beyond the subject, but it will be maybe easier. I don't know. We have no chance to have this kind of opportunity, but it could be one of also also besides the inguinal hernia, abdominal hernias maybe could be done, but we don't have, unfortunately, any experience about this subject. But we will try with you and have maybe a good chance to do that. I don't know, honestly, but it will be a good idea. But first of all, we have to be, I think, have an experience mainly on single port surgery about the colorectal disease, and then after we will switch or skip to the other parts maybe. It will be much more better because we have to have an experience in order to do a good surgery, and I hope that in the near future our team will have this experience. So thank you very much for the question.
No, I would like to have your experience and also Professor Shawki, for both of you regarding the diverticulosis and robotic surgery.
I think
because you were conservative a bit about talking about that,
sure.
so I would like to know your...
So this is a complicated condition. I think before the technique, how you approach, the timing is very important in a patient with diverticulitis management, because gradually the incidence of diverticulitis is increasing in our country. So the classical approach with the cooling period, then if there is no perforation, electively we do the colonoscopy 6 weeks later of the first attack, and if it's an indication for removing the sigmoid colon, for this we are trying to create the environment that we don't need to create an ileostomy first, but you need to rule out the possibility of the malignancy. Then for the robotic or laparoscopic surgery, the management strategies are the same. But for both conditions, it won't be easy because of the inflammation and because of the inflammation, and even with the stenotic patients, there is a high risk for injuring the other organs, including ureters. So we still advise to apply the stents if there is a suspicion for the ureteric adhesion. So it won't be easy anyway, without regardless of the size of incision. The operation will be tough. It depends, but at least, because when you think the other part, if there is a risk of malignancy, you are just waiting 6 additional weeks, just watching the patient. Yeah, you can do it earlier in the high suspicions. You don't need to wait for it. But if it's a regular attack in outpatient clinic, you can just advise the patient, apply the antibiotics, wait for 2 more weeks, and then do the standard colonoscopy. But if there is a CT scan suggesting you with the lymph nodes invasion, no need to wait 6 weeks. You can just right away do at least a rectoscopy to see what's inside, and then plan your strategy, of course. Thank you for the question.
Professor Tara is about the SP for diverticulitis or timing of operation.
No, the experience of robotic surgery in diverticulitis, with all sequel, perforation, bleeding, and all. I mean, you are facing a case of diverticulosis.
You can use robotic surgery for Henshi 3 and Henshi 4 if you want to. If you have to operate emergently on a patient, you can use the robot to operate on Henshi 3 and Henshi 4. You don't have to do it on open. It depends on your comfort level and your expertise with using the robot. So if you need to operate emergently, yes, you can do that. If you need to operate emergently on obstructed hernia, yes, you can do that. If you need to operate emergently on strangulated necrotic hernia, yes, you can do that. It all depends on how comfortably you can drive this vehicle in this environmental situation.
Thank you.
Can I have a minute? This is your video, right? So this one is the XI, correct? Yes. And then I want to show after that the one that you used SI for the, okay? So if you play this one, please. This is what I was referring to as different in how to drive the instrument. This is basically straight instrument with 3D tip. And you can do straight line the way you want it without any problem. So the transition from laparoscopy to this was actually an upgrade. because they use the same instrument that you are used to with a better version of tip that can go three different way, right? Which one is your SP? The one after this or the one before this? Can you go for the video before this, please? Before this? The one before this? The one before? Nope. The one before. Yes, thank you. Yes. So look here how it is working, the crab hand. And he can never do one straight line that you do with the XI. So this is something that you have to recognize, especially with colorectal. Unlike any other small organ, when 2 centimeters is enough to dissect the vessel, for us, you need actually more than 15 centimeters to get everything mobilized. So you can see he's doing snip, 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 and compensating for the difference between straight instrument with 3D tip versus elbowed instrument with 3D tip. So this is one of the things that I had to learn in order to do colon resection. And you cannot find this for prostate. You don't have to find similar thing for transvesical, or even gynecologic you could feel that difference, but also their field is not as big as ours. I hope these 2 videos demonstrate what I was telling you. Thank you, Professor. Thank you.
Any comments or questions? So, we give a big applause to these great 2 robotic surgeons. Thank you very much for your presentations. Thank you very much for all the audience late hour standing with us. So I'm going to close the session. Hope to meet you soon again somewhere in Turkey.